One of the traps that I think we all fell into as overdose deaths astronomically increased and reached record highs was that overdose became our only metric of harm that seemed to get traction publicly, but also seemed to mobilize people to invest in harm reduction services. This is where grassroots organizing, underground access, underground efforts are going to be what keep us going. And this is where researchers stepping outside of their ivory tower bubbles and thinking creatively about how can we continue to do the research and show what we're doing is working, even with or without federal funding or with these constraints. And I think that this is a time where we need to learn from our elders.
You're listening to Narcotica, a podcast giving you the straight dope about drugs and the people who use them.
Misinformation may seem like just that stuff your weird uncle believes, but obviously it has real-world consequences. Otherwise, we might not be under the current avalanche of bullshit that is dictating society. From climate change denial to vaccine skepticism to really fringe stuff like fluoride being radioactive or whatever. It goes without saying that misinformation is a public health crisis. And that extends to drug policy as well because it does cost lives. Syringe access and supervised consumption programs are under attack and losing government funding. Even testing strips are on the chopping block, while harm reduction itself is becoming a taboo term. And I don't like to make predictions, but it all seems like it's about to get a whole lot worse. We're going to get indentured work camps, euphemistically called treatment farms instead of effective rehab or drugs like methadone. Overdose metrics may go away entirely because the government doesn't like data anymore. Meanwhile, cops in the DEA are getting more and more funding to imprison people for doing what they want with their bodies and minds, and on and on. So, what do we do about this? Well, let's talk about that. I'm Troy Farah, and you're listening to Narcotica. Over the years, we've devoted numerous episodes listening to elders and drug policy reform and asking them what's keeping them going. The consensus seems to be that harm reduction will need to return to its roots. The movement has stood up to draconian drug policy against all odds many times in the past, and the present is not so different. Even if such principles of bodily autonomy was returned to the shadows, those who care about people who use drugs will continue applying radical acceptance whenever they can. Our guest today is Sheila Vakharia, a harm reductionist, researcher, social worker, and the Deputy Director of Research and Academic Engagement with the Drug Policy Alliance. She is also the author of the book, The Harm Reduction Gap, which we'll have a link to in the show notes. Before we get to that, we wanted to highlight that the Drug Policy Alliance is hosting the Reform Conference this November, 12 to 15 in Detroit, Michigan. This is not an ad, as we're not being asked to promote this. This is really just a cool conference, and several Narcotica people plan to be there, so it would be great to meet fans of the show. You can learn more at reformconference.org. Other than that, thank you for listening to Narcotica. It takes a lot of time and effort to make each and every episode. We are listener-funded like NPR and other podcasts, so a deep thank you to our patrons who make this show possible. You can join them at patreon.com/narcotica. We have a shop as well with some merch. You can find that and much more, including all our previous episodes at narcocast.com. If you want to keep up with us, do the thing where you like, subscribe, and rate us, please. We have been putting all our content on YouTube, so if that's a place that suits you, we're also on Spotify, iTunes, etc. And now, on to the show.
I'm Aaron Ferguson, and you're listening to Narcotica. Our guest today is Sheila Vakharia. Sheila is a harm reductionist, researcher, social worker, and the Deputy Director of Research and Academic Engagement at the Drug Policy Alliance. She's the author of the book, The Harm Reduction Gap. Sheila, we wanted to have you on the podcast for so long. I know you and I worked on a letter that was co-authored by a bunch of patient activists in methadone back during COVID. And it was a lot of fun working on that. It's turned into a lot since then. There's a national coalition. And that's just one opportunity that I've had to work with you. And we wanted to have you on this podcast for so long. I think all three of us have done work with you in different capacities. So we're just so grateful to have you. Thank you for joining us.
Thank you. I'm thrilled to finally be here as well. I've been such a fan of the podcast in various iterations for a while, so I'm glad to be here.
With us as well today, we have Troy Farah and Chris Moraff, who you all know.
So yeah, and since then you have this book that you've written, and we can touch base on that. But we can delve a lot deeper into not only your work, but I think a lot of the conversations that I think our work converges upon. Can you give us just a little bit of a background? I know that a lot of this is in your book, and then folks should definitely read it, and we're not going to spoil anything from that. But how you came to be interested in the work that you're doing, and part of it is how did you come here, and the other part is what keeps you going with it.
Yeah, I mean, I think the short-ish version of my story is that growing up, I always wanted to do counseling, and always wanted to work with people and to help people solve problems. And so getting a degree in clinical and social psychology seemed like the way to go. I wanted to be a therapist. And I was really committed to advocacy and activism. And so social work seemed like a good master's degree to kind of marry those two interests together, being able to provide direct services, but having that broader analysis. And it just so happened that in my second year internship placement, I was randomly placed in an outpatient 12-step addiction treatment facility. And that was my first foray into direct service provision in that kind of way. And it was my first real exposure to working in the field of substance use disorder treatment. And what I'll say is that it was a tremendous opportunity because I loved working with people with substance use disorder because they ran the gamut. I was working with people of all genders, all races, all ages, all demographics. And so many of my classmates in social work school were so focused on only working with older adults, only working in hospice, only working with children and families. And I really wanted to work with all kinds of folks. And so being at that treatment facility was a great way for me to be able to work with a variety of clientele. And while I learned that I loved working with such a diverse clientele, I quickly came to grow uncomfortable with the way in which we were providing services. So, as I said, it was a 12-step oriented treatment facility. And so, self-identifying as an addict or alcoholic happened at the top of every session. We facilitated people having to go to 12-step groups outside of treatment. We often read the big book and various aspects of that literature in treatment. And we regularly urine drug screened our clients. When I got a master's in social work to be a therapist, I did not know I was going to have to handle so much urine, but I did. And about a third to a quarter, I'd say a third to maybe 40% of my clients were mandated to treatment in some way. So they were either probation, parole, drug court, child welfare, which we also call the family regulation system, or they're through social services as a mandate to be able to get their benefits. And I had to get my clients to sign releases so that I could talk to these referral sources to let them know how the clients were doing in treatment. Because if they weren't complying, if they were testing positive, that could lead to being discharged from treatment or getting violated on their parole or probation and getting locked up again. It could affect their benefits. It affected their custody status. And I realized that I was no longer doing client-driven services or even being client-centered in the care that I was providing because in so many ways, I was not a trustworthy provider. I was not building the conditions for a true therapeutic alliance. And I did not deserve their honesty and their truth because oftentimes what was said in treatment would get reported back to sources that could really have tremendous ramifications on their lives. And so after doing that for a little bit, I was ready to make a change. I still wanted to work with the same community, but I didn't want to work in that kind of modality. And so I went straight to a syringe service program and got a job as the sole mental health provider at a syringe service program. And while I was there, really actually learned what harm reduction was as I was doing it. And at the time, the only reason I knew I wanted to go to that program was because I wouldn't be ratting out my clients, because I wasn't going to be piss testing my clients, and so that I could actually work with them on the goals that they wanted to work on. And becoming a harm reductionist happened while I was there, getting supervision, seeing what it was like to work in a setting where literally the office next to mine was where people were picking up their pipes and their syringes and their naloxone. And that's when I became a harm reductionist. And I did that for several years before deciding to go back to grad school to become a professor, because I felt like as a social worker, I didn't learn very much about harm reduction in school. And so I wanted to build the next generation of harm reduction social workers if I could. And then becoming a professor, I loved teaching the students, but I started also seeing that if I really wanted to have a bigger impact, it was the policies and the laws that were actually affecting people's lives that needed to change. And so that's what brought me to the Drug Policy Alliance, where I help them bridge the research policy divide, and take all those experiences that I had as a direct service provider, remembering the clients and the people I served, and bringing all of those experiences to the kind of work that I do. So I've had a meandering path in the field, and I've been able to kind of be in different facets of it, but working with people who use drugs and to help improve the quality and conditions of their lives has been a big part of what I've done. And I guess in this current moment, remembering that there are people out there who are doing this work on the ground every day, even though I'm not on the ground like that every day, is what fuels me, because I know it's so needed for us to keep fighting at the policy level, for us to keep promoting good research, for us to keep finding ways to spotlight their expertise and uplift their voices. And I feel like that's the best way I can be useful in this moment and not give in to despair.
Yeah, thank you for that. I really do appreciate your book, The Harm Reduction Gap, because it's just very thorough at explaining what harm reduction is as a philosophy and a practice. I don't want to get into politics too much, but I'd kind of like to do a temperature check. How are you feeling about this moment for the harm reduction movement? As most people probably know, it began as a grassroots movement. I've heard a lot of criticism that it became sort of institutionalized under President Biden, but now Trump and RFK Jr. are at the helm. So how are you feeling about what's going on right now with harm reduction?
So I love that in my bio, I didn't mention my book at all. So thank you for bringing it up. But in this moment, I have to say that the signs of the backlash had already been appearing for the past few years, sadly, right? Those of us who've been watching and listening to conversations at the local level, at the state level, in red and blue states, in red and blue cities, have been noticing the tide has been turning, not only on drug policy and harm reduction, but on other broader social issues as well, reproductive justice, queer rights, trans rights, etc. In some ways, I think the election of this current administration is just is the culmination of several years of a backlash building against progressive movements, against humanistic movements, and against, the building of a social safety net and serving some of our most vulnerable and marginalized communities. And so in some ways, while it's absolutely devastating to see the ways in which we're seeing dramatic cuts in federal funding that trickles down into actually helping programs to do the work that they do, dramatic cuts at the research level to be able to study the kinds of things that we need to do to understand and address our issues. In a lot of ways, this has been several years in the making. And I think it sadly means that the ways in which harm reduction had been palatably institutionalized through public health departments and what have you, was a sign of increased funding and acceptance of harm reduction in certain spaces. And now that those spaces are going to get defunded and are getting defunded, public health departments losing money, all of those things, in some ways, we're going to be forced to return back to that grassroots element, because it's the folks who've been doing this work the whole time, unfunded, with little funding, in red communities, in places where syringe services are still not even decriminalized. We're going to have to return back to those roots of being a renegade movement by people who are scrappy, who are making the most out of what they have, and who are saving one another's lives, because that moment of professionalization in our movement did lead to a lot of funding and support. But now that some of that funding and support is going to be leaving and has already been leaving, what we have to lean back on is that infrastructure that had existed before, and to somehow return to the lessons of the 90s and the early aughts of folks who did this work with very little support financially and publicly.
Thanks for answering that. I think you're right that this backlash has preceded the recent election here in Philadelphia. Our mayor, Parker, who came after Kenny, cut every city dollar from syringe services. They've been sweeping and arresting all up and down the Kensington corridor in ways that they hadn't been for years. So I think that there was a tenor that sort of I hate to say it, but I think it really revolved around, when it really sparked here at least, was the argument over supervised consumption, and the safe house battle that it really brought MAGA supporters and Democratic councilmen out, like, on the streets marching together, which is the craziest thing I'd ever seen, And I guess, as somebody that watched that movement unfold, and I've been to On Point, I'm sure you've been to On Point and seen it, and like, what do you think is going to happen? I mean, let's not like underestimate that they're cutting like 50% of the workers from SAMHSA, as I'm reading, and like, I've heard that even the term harm reduction is not going to be allowed to be used in federal. I guess I don't know how they would do it. Same way with diversion and inclusion, or submit perhaps. I don't know if that's like a rumor. That's true. I guess everybody I talked to is like in this like sort of panic about what's going to happen. And I think you answered it well in the last question, answer. But I mean, I think this is really like unprecedented, because where before we just didn't have support, it seems like now we're actually going to have like a strong opposition. Then I worry for like On Point. I mean, that they've done great work there, and like, what do you think could happen? I mean, do we have a future with are we going to lose certain services? Pennsylvania doesn't have certain services. We have a bill that's supported by Republicans, but that could change if the memo comes down from on high that they're not going to be supported if they support this bill.
Yeah, I mean, I think time will tell to see the ways in which the federal administration is going to intervene. And I think that the hope that I need to carry with me is the excitement around Providence's site opening, still despite everything happening at the federal level, the talks that are still happening in Burlington to potentially, start moving forward with opening their site. And the hope that at the state and local level, there'll be some degree of support or defense against federal interference here in New York. But again, time will tell. And we know that the administration has so many priorities right now. And it seems like every 5 minutes we're hearing of a new executive order on some new issue that none of us ever thought about before, that all of a sudden now is coming to the forefront. So one can only hope that in the flurry of all the activity that's happening federally, that this is one of those things that hopefully at least temporarily slips through the cracks, so that the continued work of these organizations can keep going, and also the jurisdictions that are trying to move forward with new sites can happen. But I do think that this is the moment for us to return to our renegade roots. This is where grassroots organizing, underground access, underground efforts are going to be what keep us going. And this is where researchers stepping outside of their ivory tower bubbles and thinking creatively about how can we continue to do the research and show what we're doing is working, even with or without federal funding or with these constraints. And I think that this is a time where we need to learn from our elders and realize that our elders and folks who are still with us learned a lot and did a lot with very little. And I think that we as a movement are going to have to do that. And unfortunately, I think also it's going to mean irreparable damage and harm and setbacks that we can't even grasp right now, right? I think that there are going to be tremendous losses of knowledge, of people, of leadership, of our community. And somehow we will persist, but we will continue. But I am worried that this setback is more than just a setback for a couple of years. I do think that these are generational setbacks.
I would tend to agree with that. And it's had an interesting effect on drug user organizing. I'm involved a lot with National Drug User Union. I'm on the leadership team there. And in many ways, folks say this is nothing different from what we've experienced thus far, which is just being disregarded and left out of the conversation. But at the same time, it's like we've lost so many of our elders. So we don't have, especially during COVID and leading up to COVID, we've lost so much of the lineage of the organizing that's happened. And there's only a handful of folks in the drug user organizing space that are even around still. And, it's all, when things like this happen, we harken back to the last time this administration was in power and how it was COVID at the same time. And we had to find a way to come together that actually galvanized us into a lot of what we are today. And not only that, but if the people we've lost were still around, it could speak, they would tell us that It was the struggle that started all this in the first place. And we had deep concerns seeing harm reduction become mainstream because it brought actors into the space that really didn't understand it and had perverse incentives in many instances, had not seen what harm reduction is on the ground. And I like to say that you can learn more about harm reduction by volunteering at a syringe service program for a day than you can taking classes for months. By just the practical experience of interacting with people who use drugs, recognizing us as human beings, being willing to give us something that we need today. And so while it's really tough to do this work without any support, there's a philosophical aspect of it that it is a really reactionary movement. It was started by people who use drugs. This wasn't started by a government agency. It wasn't started by a health department. It was started by drug users trying to help each other, to survive. And if we can return to that in some way as a silver lining from all the things that are happening, I believe in the end it'll be worth it all.
Yeah, because if there's anything that our movement has shown is complete resilience and willingness to continue to fight. One thing that I do, though, worry about is that we are also a movement that's currently in active grief and bereavement as we are also fighting. And I know that our people are exhausted. Those who are left are exhausted. Those who are still fighting are exhausted, right? And not only from the more intensification of this third and fourth wave of the overdose crisis, seeing their friends and loved ones and partners and family members and participants losing their lives to the drug supply, but then with COVID coming on top of it, we've lost a lot of folks to COVID because a lot of our people had co-occurring health issues, right? And other kind of underlying vulnerabilities and weren't able to access the kinds of services that other people were. And so, I mean, that is one thing that does concern me, is that we've never had time and space to grieve. And I know that beyond losing people to passing of overdose or to COVID or other health issues, we've had attrition and drop off in our movement because people are burnt out. A lot of people have had to step away from the work, have had to take breaks because you can't do it all. And it's hard to be putting out every single fire and to be fighting opposition while still in active grief. And I just wanted to name that because I do feel like among the many things that our communities are facing, we don't name that enough and recognize the ways in which we are putting so many of our folks at the front line in direct fire of opposition, but also being there to have to sit with the grief and barely even be able to sit with the grief, but have to still persist.
Yeah, thank you for mentioning that. I think that's really important to acknowledge. Collectively as Americans, I think a lot of us are suffering from a sort of trauma, not just from the staggering amount of overdose deaths, the pandemic, of course, but like other things like the suicide crisis and gun violence and all that stuff. So since you kind of brought this up, like, let's talk about, drug overdoses have dropped over the last year and a half or so. And there was sort of a victory lap about this, like, oh my God, we're finally moving in a different direction. But I feel like that's not the full picture. Like, what are your thoughts on that?
So I think it's a complex issue to talk about, right? So this is where it's really important for us to talk about what it looks like to look at a broader national snapshot and maybe even to look at regional snapshots and state level snapshots, but then to actually think about, is that actually reflective of what's happening in my neighborhood, among people who look like me, among the people that I'm serving? And that's where some of these national numbers may not speak to people's experiences, right? So first and foremost, yes, actually Dr. Nab Dasgupta's opioid data lab released numbers suggesting that perhaps some of this decline was starting to happen in certain states as early as 2022, actually. But we're seeing kind of the aggregate effects of those declines over time and the way that we've been tracking the national data. But I think that one thing for us to remember is that even with the declines we're seeing at the national level, these are still tens of thousands of people who are dying, right? So, it doesn't console a person who just lost a friend or a loved one or their child or their parent or their family member to hear that numbers are going down. This is a victory lap, right? Especially if your loved ones are dying. Second of all, that national numbers don't reveal what may be happening at the regional level, because we know that regionally drug supply shifted so much, access to resources are different, and the laws are different in terms of the kinds of supports and services that people have access to. But then I think that the racial disparities have really been washed out in a lot of these broader narratives, because one thing that we've known is that the last time we were able to look at demographic breakdowns from the government's data, that Black and Native overdoses deaths continue to remain very high. And interestingly, Asian American and Pacific Islander overdose deaths went up dramatically in 2023. So again, when we look at these bigger numbers, there is reason to be grateful and to say maybe there's something happening here that's working, and to point to a lot of the extra funding for access to medications for opioid use disorder, access to harm reduction, more points of care, facilitating connections to naloxone and all these other kinds of things. But the other hand, we still have to remember our communities are still losing people every day, and it's too many people. And some communities continue to be hit harder than others. And to know that all of these gains are tenuous, right? And they were the accumulations of years and decades of infrastructure development that went into creating the conditions that these people's lives could be saved. But if we phase back any of that funding, we could see it go completely the other way again, right? And so I think that, the way we talk about these changes in overdose deaths has to be very nuanced and has to contain hope, but also has to remember that people are still losing their lives, and there's still so much we can be doing. And especially with these cuts, we could reverse these gains.
Yeah, I did want to add one more thing to that, just because one thing I'm kind of worried about, and I haven't really seen this been engaged with much, is that, overdose deaths have been going down. The context really matters, like you just unpacked there. But what if the Trump administration just stops counting? I think that is a real possibility. I mean, a couple of weeks ago, they fired the researchers at SAMHSA that did the National Drug Use Survey, which is that was insane to me. This is such a long-running project. It's not a perfect thing, but I think we run this risk of running into a vacuum of data, and maybe overdose deaths will rise again and we won't even know.
Exactly. I think that, and this tactic has been playing out in other spaces already. States that after Roe v. Wade was overturned, that didn't have their own protections in place for abortion and other reproductive rights, quietly also started to shut down their statistics department, conducting and collecting maternal morbidity data and mortality data right at the same time that these policy changes happened, because they didn't want to have the numbers to show that the overturning of Roe v. Wade was actually leading people to die, right? And was actually increasing harm. And so this is also where us seeing that these signs were there before this happened, and that this is a sign of a bigger shift culturally, an anti-science shift, an anti-data shift, but also this acknowledgement that if the data exists, then we might be held accountable to it. And if the data doesn't exist, we can then tell the narratives that we want to. And history tells us that administrations in other parts of the world at other times for other means did the same thing. They not only came after the most marginalized, but they came after the scientists, because they didn't want to know the answers. They wanted to dominate the narrative themselves. And so this is a very scary time, because if we don't have the data, we're not going to know. And this is why it's all the more important to continue funding the kinds of things that we know will likely work and that have likely worked in the past, because at the very least, we have that evidence from behind us. But again, we won't be able to do it to the same effect if those same funding sources are getting cut, right? If Medicaid benefits are getting cut, if people aren't able to access technical assistance for, prescribing buprenorphine, if some of this funding that was going to expanding access to methadone and buprenorphine gets cut, if there isn't enough federal funding trickling down for naloxone access in communities, we're going to see some really scary things.
And I'd like to add that it's also worth noting that we don't really know. I would say that so much of this decline in overdoses was a function of a supply side issue that changed the dynamics of the supply. In Philadelphia, I'm not really seeing more people recover. I'm just seeing more people in a state of more frequent withdrawal and doing less potent drugs. I mean, and the withdrawal that they are getting from medetomidine, which is a new tranquilizer that's being used, is worse in some cases than the withdrawal they're getting from fentanyl. It comes on really quick, projectile vomiting. I mean, it's like they're still sort of sorting this out in UPenn here and some of the other hospitals. And I mean, let's be real. The Biden administration wasn't really that more friendly. They strung Safe House along for 4 years, like on the possibility of opening here an overdose prevention site. That never happened. It's really, I think looking at the amount of drug use versus the amount of overdose, you would probably see that drug use is still pretty high, and like we've seen fentanyl purity in our bags here, like cut in half because of the conflicts in Sinaloa and stuff, and other factors that have nothing to do with any treatment or any options for people here. But so it could change back very quickly. I mean, there's places that you can now source nitazines like on the street. I mean, where not just online vendors or whatever. I mean, they're being sourced locally. So there will be something coming down the pipeline. The UN just made bromazepam illegal. Or they scheduled it under Schedule 4, which is the dominant analog of benzodiazepine analog that's used to make counterfeit Xanax here in Pennsylvania and probably most of the East Coast. What's going to come next? I mean, because they're gonna put something out, and so we just got to get out of this mindset that if we keep fighting this war offensively and with all we got, it's been 50 years and we've had higher overdoses and cheaper drugs in the past 10 years than I'd ever seen before. I mean, we just need to really consider a new tactic, and it's certainly not going to happen under the Trump administration. But it leaves me as someone who's covered this sector for such a long time with just like the feeling that I'm repeating myself over and over again to the same people that generally agree with me. And
Yeah. This is where you find points of divergence. Yeah. Well, and I think you bring up some really excellent points, Chris. And one of them being that one of the traps that I think we all fell into as overdose deaths astronomically increased and reached record highs was that overdose became our only metric of harm that seemed to get traction publicly, but also seemed to mobilize people to invest in harm reduction services. And I think that one of the things that you allude to, Chris, is that overdose is not the only drug-related harm that our communities are facing. And if it's the only one we measure, and if it's the only one we tether our ideas of success to, and especially if the numbers are going down, we don't want to take people's eyes off of our issue, because it's not that just because people aren't dying of overdose, they aren't experiencing harm, right? Like xylazine-related wounds, the heavy sedation, these withdrawal symptoms, these unknown side effects and effects of intoxication. We know that HIV and Hep C risks continue to remain really high. And, some of the people funding the most Hep C access to treatment are the pharmaceutical companies themselves, right? So we do need to remember that we need the public not only to remember our communities when it comes to saving their lives from overdose, but to think about quality of life and so many other health metrics, skin and soft tissue infections, endocarditis, all these other drug-related harms that still persist in people who are still here with us, right? So say they aren't dying of overdose, we need to address their health needs when it comes to all of these other issues. And I do think that we all, and I include myself in this, really latched on to using overdose as such a clear, tangible, mobilizing. It was so clear that you were mobilizing people to save lives. And then this framing of being able to see someone who died of an overdose as an overdose victim and all of that work that went into that, but then not actually, victimizing them in death, but not actually creating space for them to have full lives in life, right? And what are we doing to help improve their lives while they are still here with us? And acknowledging all the harms that they still continue to face while they're here walking the earth with us.
And that's a great answer. And I had a question at a presentation I gave recently that I just found myself stumped. I couldn't answer it. Somebody asked me, is there a resource for non-fatal overdoses that wind up with people comatose? And I couldn't come up with one. Maybe you could help, but I don't know if those people are even tracked. I mean, they're not fatal overdoses, but there's lots of people that are winding up in the ICU and because of lack of oxygen, not coming back.
It's also a big problem for states that don't have a good Samaritan law because, if people are not emboldened to report an overdose or respond to it, or if they're worried about being charged with a drug-induced homicide or something like that, you're never going to hear about it when it's a non-fatal overdose.
Yeah, and the only tracking that we have for real solid surveillance data on the prevalence of non-fatal overdoses are this system called the SUDORS system, SUDORS. And even then, it's still based on EMT and ER data, emergency room and 911, emergency staff tracking if they've been called or responded to an overdose that ended up being non-fatal. But again, I still don't even know what's going to happen with the SUDORS system, and not all 50 states participate in it. It's like 20 some odd states. And, Dr. Dasgupta's lab did a really good job of showing that even SUDORS data coincided with the national declines in overdose deaths, and that even non-fatal overdoses that involved, calls to EMS and to, trips to the ER went down dramatically. But again, we're still talking about, something like 80 to 90% of the overdoses that are experienced on a daily basis being non-fatal, right? People wake up, people don't die. And so what are we doing to help them? And I recently attended a webinar featuring Matt Bond, who is an amazing Canadian drug user activist. And his presentation was with a physician, and they had done a bunch of research on people who had had oxygen loss to the brain during an overdose, people who were revived from an overdose but had some sort of brain functioning disruption because of lack of oxygen to the brain. I can find that and send you the link to that. It was a really informative webinar about, like those seconds and minutes that people are going without oxygen, even after being revived, can have functional effects on the brain.
One of the things that really concerns me about what's going on right now is this idea that really getting people into treatment is the answer. Because we know that treatment, and as you point this out in your book quite a bit, but we know that when we're talking about treatment, what we're talking about by and large is abstinence-based, 60 to 90 day treatment that puts people in this highly religious environment in most instances, or that steeps people in sort of an environment of having to identify in a certain way, having to use certain terminology and adopt certain beliefs. And if they don't, they're considered just not ready. And so it seems, with RFK's rhetoric, about this topic and what the proposed solutions by the current administration are, which is that we're just going to get everyone into these types of treatment that we've used in the past. To me, the healing farm idea was no different. It was nothing new. It was no different from what we already had in the form of either therapeutic communities or, abstinence-based treatment programs. And so I think we can expect to see a drastic rise in people entering these types of treatments. And so few of them have any linkage to harm reduction services. So few of them have any linkage to methadone or buprenorphine. And I'm concerned about what happens because those places are not going to just house people indefinitely. And people are at a drastically increased risk of overdose when they're released from an abstinence-based environment. For people who use drugs, we know that being released from jail or from an abstinence-based treatment center can significantly increase the risk of overdose. And then you stated another statistic in your book that I found interesting, but it was the ratio of syringe service programs to treatment providers. You said that there are 35 abstinence-based addiction treatment providers for every syringe access program. And so what can we do amid this crazy political and cultural climate to take a look at the vast disparity here between what works and what's culturally acceptable? Because to me, as far as I can tell, you mentioned, science denial. I think that we have a situation of epistemological bankruptcy going on right now, especially with someone like RFK, who's full of conspiracy theories and thinks that, brushing your teeth is going to lower your IQ. How do we get to the point where people actually realize, okay, they're going to go away to this treatment and that already hasn't worked. It's been proven not to work, but then what do they do?
Yeah, those are big questions. What I will say is that addiction, however you want to classify it or call it, is the only currently so-called medical issue, disease, disorder, whatever you'd like to call it, that still is marred by the fact that it has all substance use and intoxication have always been seen as a form of moral deviance, that has like imparted in it like this idea of like the sinful, indulgent, hedonistic user, right? And so like that moral framing has always infiltrated how we treat people who use drugs. And as soon as our criminal legal system really became formalized as an enforcement mechanism for what we deem moral and immoral, they went from being immoral deviants and bad people to criminals, right? And then simultaneously, we've had and I'm writing about this right now because I'm working on my second book. But simultaneously, we had the emergence of people saying it wasn't that these people were morally bankrupt, it's that they needed a spiritual foundation, right? And that was kind of at the root of some of the first framings of recovery circles and healing groups and temperance advocacy, saying that, you know, the habitué or the drunkard or the habitual drinker needed a spiritual awakening to recover. And then as our medicalized systems became more formalized, physicians and you know, theorists in those spaces started to say, no, but it's a medical disease. It's a medical issue. And so I think we still live in a place where all of these models still play out, right? The morality, the criminality, the spiritual lacking, and this medical condition. And I think that, you know, RFK's discourse and his proposed solutions feed very much into this kind of need for a moral reframing and re-education in these farms, right? But also like the spiritual underpinning, because he credits 12 steps and AA is like such a big part of his recovery journey. And while I, like you, Aaron, have a lot of critiques about the medical industrial complex saying that our issue is under their auspices, his complete denial of any of the valid contributions they've made in the form of these medications that save lives is dangerous. So, but I think that this is like the perpetual American dilemma. Is addiction a moral issue? Is addiction a crime? Is addiction a spiritual lacking, need of repair and reorientation and awakening, and being saved? Or, you know, is it a disease for which people need to be treated? And I think that all of those tensions continue to play out and are just out on display with what we're hearing from RFK. I don't know if that answered your question, but it's a rant that I like to go on.
Yeah, I just think it's something we're going to have to start grappling with routinely because this was already the dominant ideology. But now and this is where I was almost worried because I wanted the government to just ignore us as drug users because I knew that the second they started actually paying attention, this is what it would become. Right. And I went through a therapeutic community. I spent 9 months, standing at attention and doing the whole thing. It was all behavioral modification. And like less than 1% of the guys who went through that treatment center actually stopped using. Most people just start using again when they get out. So it's like, it's kind of just putting things on hold. I guess that's sort of the modus operandi of a lot of things that are happening right now. It's just like, well, we'll make the market go up and down every 2 months, and who knows what's going to happen in the next 3 months. So, and rather than house people, send them away to a treatment center for 30 or 60 or 90 days, and we'll deal with them when they get out. But harm reduction has always dealt with people like not necessarily in treatment or not necessarily even wanting treatment. It engages people at all levels of this continuum. And I can't think of anyone else or any other entity that interacts with people across that span. It's not just people in treatment. It's not even some of the people that harm reduction agencies deliver services to have been out of treatment their entire lives, and they continue to receive those services. They've never been to treatment, but treatment providers never see that. They never interact with that guy who's never been to treatment, doesn't want to go to treatment, but is still showing up to the syringe service program to get their supplies. And that just seems to be a hidden population of people.
Yeah. And so in my book, I call all of us, I say that all of us are living in the harm reduction gap, right? So what I coined in my book is that our current system is built with two people in mind and two people only. Trying to get someone from ever trying drugs through the Just Say No drug prevention that we provide to our youth and our young people at the front end of their lives, saying drugs are bad, this is what they do, don't use them, and you'll be fine, right? And then what we do is on the other end of the continuum of our care is we have all these high threshold, very intensive treatment options, whether they're outpatient, detox, inpatient therapeutic communities, residential, rehab, what have you. And those settings are only meant for people who meet diagnostic criteria for an addiction, whose substance use is problematic enough that they have reoccurring negative consequences due to continued use, right? Despite attempts to stop. And then we say, we've got this system of care for you. You've got a really severe problem. And the solution is to never use drugs again. And these settings are going to help you do that. And then what I argue is that the rest of us live in that gray area in between, because the second you have a sip of alcohol, the second you take your toke of your first joint, the second you do your first bump of cocaine, the second you have your first cigarette, you now have violated the terms of your Just Say No drug prevention education. And now you're off to the races and you're off on your own. It's up to you now to learn how to stay safe, how to moderate, how to manage risks, how to take care of each other in a crisis, and how to navigate your lives and your responsibilities with whatever role you want to have substances play in that. And in this harm reduction gap of people who don't qualify for treatment and have said yes to drugs in some capacity, the social, recreational, occasional user, but also the person who might be engaging in higher risky levels of use, or the person who meets diagnostic criteria but can't afford a treatment program, can't get off a wait list to get into a treatment program, doesn't have transportation or childcare to be able to access treatment. I argue all of us are in the harm reduction gap because we are left to fend with drugs for ourselves. And many of us survive, but many of us don't. And I argue that the harm reduction gap includes people who successfully completed treatment but return to use, because we know that it's not just people who drop out of treatment who sometimes dip and dabble again and return to use after treatment. It's even people who successfully completed it by whatever terms the program deemed as success, but also people who were kicked out, people who dropped out, people who couldn't afford to keep paying for treatment. And what treatment facilities have to say to people who end treatment is absolutely nothing. Go to a meeting. Good luck. And we'll see you when you're ready to come back. And harm reductionists are that safety net. Harm reduction is that safety net for anyone who's been through treatment, whether they successfully, quote unquote, completed it or not, and still needed support and tools to stay safe, but also the millions of us who will never set foot in a treatment facility. It's still, the NSDA, rest its soul. Sorry, it's not there with us anymore. The National Survey on Drug Use and Health. I did my dissertation research using NSDA data. But the NSDA tells us that, upwards of 90% of people who meet criteria for an addiction do not receive treatment in any given year. I would argue those are people who would be tremendously served by harm reduction. The NSDA also tells us that 70% of Americans over the age of 12 used some form of an intoxicant, whether it was nicotine, alcohol, cannabis, or any other illicit drug, and just had to stay safe. Right? So I argue in my book that all of us need harm reduction, whether it's learning strategies for using safer tools and equipment, whether it's knowing how to respond when someone's in an emergency, whether it's having access to naloxone, whether it's having someone to support you achieve moderation or reduced use goals, or helping you transition from a higher risk substance to a lesser risk substance, or to transition from injecting to smoking. All of those things are what harm reductionists can do.
Absolutely.
I kind of want to talk a little bit about Measure 110 in Oregon, the bill that decriminalized drug use there. I think there's just been so many warped narratives about what happened there. And I know that the Drug Policy Alliance was pretty heavily involved with that, and it got repealed because it kind of touched on all these other things you've been mentioning in this interview. It's just like it decriminalized drugs to a degree, but it didn't solve all these other problems. And so people kind of saw the bill as a failure because it didn't solve homelessness and it didn't have all these other, it didn't wave a magic wand and fix all these issues. Can we talk about the backlash there and what we can do to go moving forward?
Yeah, I mean, first of all, for anyone on the call who's not familiar with Measure 110, it was a ballot measure that was introduced in the state of Oregon to decriminalize the personal possession of illicit drugs. And nearly 2/3 of Oregon voters voted in support of passing Measure 110 in November of 2020. And it went into effect in February of 2021, right during, in the midst of the COVID-19 pandemic, right? And beyond just decriminalizing personal possession of these substances so that people did not have to face incarceration and arrest and a criminal record for the rest of their life, um, it also created a continuous funding stream that took cannabis tax revenue money and invested it into the health, recovery, housing, harm reduction, and treatment infrastructure across the state of Oregon. It invested over $330 million into this infrastructure in the state of Oregon. And oftentimes, this is a piece of the narrative that's never really given the bandwidth that it deserves. Not only were we decriminalizing personal possession, we were opening up channels of funding that had otherwise been inaccessible to public groups on the ground, because largely treatment is funded by insurance, and also a lot of grants and nonprofit funding comes from other kinds of funding streams that often don't pay for the kinds of things that programs need to get off the ground. And, even federal block grants that are given to states to build up their infrastructure have limits on what they do and do not pay for. And so that cannabis tax revenue money was actually meant to pay for things that wouldn't have been paid for by an insurance premium, would not have been paid for by a block grant. Things such as helping to convert a local motel into recovery housing. That's not something that you could find funding to do. It was the kind of funding that paid for a peer recovery workforce to get hired. It was the kind of funding that paid for needles and safer smoking equipment, and it paid for naloxone access. It paid for peer recovery coaches. It paid for mobile vans for outreach. It paid for different kinds of staffing and training and infrastructure development that hadn't otherwise been able to get funded. At the time that Oregon instituted or implemented Measure 110, it ranked 49 out of 50 in states for access to care. And we were trying to build up that infrastructure with this money. And so every region in the state developed behavioral resource networks that actually had to build up a continuum of care in their county. And they had to actually grant out money to organizations in their counties to make sure that they had every level of care in every county. And they had special earmarked monies for BIPOC serving organizations. Some of the first Spanish-speaking treatment programs and harm reduction programs were funded with this money. This money went to Native and Indigenous healing practices. This went to programs specifically serving Black communities. And so, again, this narrative was never really part of how people understood what Measure 110 did. And when I have this conversation, even with people on our side, many of them did not know that this is what Measure 110 did. But again, remember that when decriminalization was put into effect, who were its enforcers supposed to be? Law enforcement. This was a great policy on the books, but our primary enforcers were not buying into the policy that they actually were at the front lines of. And so we have to remember that this law was also passed in the midst of the COVID-19 pandemic. But, law enforcement in Portland and in Oregon in general, just like in a lot of other parts of the country, were still kind of reeling from the George Floyd protests and feeling like this was an so-called anti-cop moment. And many of them reacted in how they responded when Measure 110 was implemented with that kind of, you don't think you need us? Well, we're not going to be at the front lines of this, right? We're not going to be helpful to this. And unfortunately, it was their narratives that often got a lot of the spotlight. But all of this to say that I think that, yes, so what happened in September 1st, 2024, is that the criminal penalties came back for possession, but about a third to maybe a half of counties claimed that they were going to engage in a humanistic kind of diversion program in their county. So we understand that it is a health issue. And although we don't want everyone just walking the streets, we do want to use that contact with law enforcement as a way to divert folks to care. The problem is that not all counties had an in-place diversion program at the time that decriminalization was reversed. So what we know is that people were starting to get arrested and locked up again. And what we also know is that even in the counties where diversion programs were supposed to be instituted, it took a while for them to get off the ground. And oftentimes these diversion programs had the problems of a lot of diversion programs. They only wanted first timers. They didn't want people with too many other charges on top of it. And so it still would exclude a lot of the people who needed it. And fortunately, that funding has remained preserved, which is, I think, the biggest victory for us, is that everything is not lost because drugs were recriminalized, because that funding remains in place, that imperative remains in place, and the trickle effects of the ways in which we invested in communities, I hope will continue to ripple forward in the years and decades to come. But yeah, it was a challenging moment.
Wow, thank you for that. I think that is probably the best explanation of what was happening with that law that I've ever heard. And honestly, some of that was news to me. Like, I didn't know some of those details and how it was using that funding to help people. It's very different from the narrative you hear from, the right and Fox News and stuff like, oh, this was a law to let people get high and drop out of society and everything. And I did sense from a lot of reporting on the issue, especially from interviewing law enforcement, that there was a little level of resentment about losing a little bit of that power. And yeah, the whole defund the police movement and Black Lives Matter, I don't think it's an anti-cop movement. I think that's just too reductionist, and we don't need to get into that. But I can see why some people did, latch onto that very simple narrative. So thank you for debunking that. But
yeah, and I would love to share some resources with you, because a lot of research has already been conducted on the preliminary outcomes. And what we saw was that the evidence showed that the biggest thing that we wanted to see dropped. Arrests dropped, right? And we did not see overdose deaths go up. And we still continue to see, increased access to services. The other thing, though, is that cops still were contacting people who use drugs and just harassing them on other charges. Increased numbers of studies that came out, qualitative studies with people who used and injected drugs, showed that they were still being harassed by cops, but maybe they weren't getting arrested. Maybe they were getting booked on some other charges. And, we need to follow the research to really understand what implementation was experienced like on the ground. And there are qualitative studies that said, despite people thinking that decrim gave a free pass, upwards of half of people who injected drugs didn't know that fentanyl possession was decriminalized. Sadly, that's a PR problem on our end, but it also goes in the face of people thinking that, people who use drugs themselves thought there was a free-for-all. A study by researchers from RTI found that people thought it was only a few drugs or just one drug or whatever. They still didn't really understand how it all panned out. And so, again, this idea that there was some sort of widespread knowledge that this was a free-for-all, even for, people who use drugs, is not true, and that it somehow kept people protected from law enforcement contact, although it meant that they weren't getting arrested and booked. Sadly, people were still experiencing that. And I would love to share with you a symposium, an all-day symposium that was hosted by researchers at RTI that actually featured 8 hours in that day of panels of research that actually showed what it did to overdose, what it did to arrest rates, what people's experiences were, what kind of programs were funded. And then I also want to share with you a dashboard that's being operated by the state of Oregon, in which you can actually go in county to county and see where the Measure 110 money was spent and what kind of services were provided, because I feel like that's also a piece of information that people don't really have.
Yeah, I think it's so important how we frame the discussion around this, because it's similar to what happened in Canada with the Safer Supply Initiative. I saw a study looking at hospitalizations during that period and claiming that hospitalizations increased during the period of safer supply there. And I heard folks jumping to the conclusion that it had no effect on overdose. First of all, it is just so hard to get population level impacts from smaller programs. I mean, for one thing, we have this massive drug war that's been waging for decades upon decades and this burgeoning illicit drug supply. And you expect it to be, you expect the entire population level effect to be impacted by a single program. But that's the bar that people have for this type of thing, I guess, because it's so counterintuitive. But, at the same time, it's like what you said, the absence of evidence is the evidence of absence where evidence is expected. If we believe that drug use is causing overdoses, then making drugs more available or failing to incriminate drug use should contribute to a rise in overdoses. And when that doesn't happen, that's its own type of evidence that has to be acknowledged and communicated. But that seems to be just completely skipped in the conversation because there's such a high bar for so many of these things. You know, it's tough to grapple with the messaging aspect of it because people will jump to that conclusion. They'll say, well, we tried it and it didn't work, you know?
And, this is where the double standard comes into effect, right? People who uphold the status quo of punishment, enforcement, supply side interventions, they want the data when it suits them. And oftentimes when we tell them what we believe in, they'll often ask us, well, what's the research, right? My whole job at DPA is arming my policy advocacy colleagues with the data to back up in case anyone says, why are we advocating for this policy? And it's so funny that I spend, me and my colleagues spend hours toiling over the language in these fact sheets, coming up with talking points, speaking to the research and the evidence, and they hand it over to a legislator or they hand it over in a conversation. And then people really still go, well, I don't know. I mean, the study, is it really saying what you think it is? But I saw this guy on the corner and he was really having a hard time. And like, are you sure that this is really speaking to that? And so, there's the standard in which we're supposed to be armed with evidence at all times, but yet when it goes in the face of the emotional or the anecdote that people are holding on to, then it gets, conveniently disposed of, and then we're still invalidated for what we say. When we use emotional arguments, they tell us that we're being too emotional, we're being too soft, we're being too permissive. What's the research that this is going to work? We show them the research, and then it falls into, well, you didn't look at everything. I didn't see this pan out in my life, and because of that, also this anti-science moment. So, I mean, we are in a double bind, and I feel like we've always been held to this standard that the mainstream has not. And this is the burden of being on the outside. This is the burden of being who we are and carrying the torch that we do for people who are marginalized, people who are not seen as human until death, which I just find extremely troubling in this work.
Yeah. Well, I mean, I'm just so glad that you are here carrying that burden and that it's falling on the shoulders of people who refuse to desist from the cause and the purpose that really drives all of our lives. The people who are continuing on. I think if there's one thing that all of this is going to show, is it's going to show who has the incentives that endure in this work and who is working from a place of purpose. I think it is going to burn out a lot of that dross. So we're just so grateful for you and the work that you've done. The message that you provide in your book is one that I would recommend to anyone who is interested in any capacity to learn about drug use, harm reduction, just anyone even who has a sense of curiosity about what's going on in the world right now with regards to overdose and drugs needs to read this book because it does such a good job of succinctly capturing the problems that we're facing right now. And it does it in a way that I think pretty much anyone could understand. So I really appreciate you doing that. But also really, I'm grateful for your ability to communicate these topics. I think we need more people who are able to do that. It seems that the wrong message has been getting out. And so we really appreciate you being here to help with that.
Thank you. Thank you so much.
Yeah, I will second all of what Aaron just said. Is there anything else you want listeners to know about? Anything we might have missed in this conversation?
No. I mean, I think that, Miriam Kaba says it best, hope is a discipline. And I think that in this time of just unprecedented everything, what we need to do is we need to still, as best as we can, hold on to hope for ourselves and for our communities. I am so heartened every day that I meet folks doing this work in various capacities, knowing that, not one of us is alone in this, even though sometimes it feels like we are alone in fighting. I just want to leave us all with a message of hope. Our movement has gone through a lot and we've persisted. We are on the shoulders of giants, as they say, right? We weren't the first ones to fight these fights. And if anything, we've had the privilege of learning and having the infrastructure that our elders built for us. And so we owe it to them and we owe it to future generations to keep up the work.
Absolutely. Sheila, where can people find you online?
I'm on X, Blue Sky, and Instagram at My Harm Reduction. I'm also on LinkedIn, Sheila Vakharia. Please check out my book, The Harm Reduction Gap with Rutledge, Taylor and Francis. And follow the work of the Drug Policy Alliance. We are trying to end the war on drugs and promote policies that are grounded in human rights and public health and science and compassion. And I think we need a lot of that right now.
Thank you so much, Sheila.
Absolutely.
Thank you.
Thanks for listening to Narcotica, an independent production by Narco Media. Co-hosted and co-produced by Troy Farah, Christopher Moraff, and Aaron Ferguson. If you like the show, you can find out more at narcocast.com and support us by joining our Patreon. Just go to patreon.com/narcotica. We are excited to announce that a portion of the proceeds from the show will now go toward the Urban Survivors Union, which is the National Drug Users Union, a group of directly impacted advocates for drug user health in America. This is the way social change happens from the ground up, and we are so excited to support this group that is doing such important work to fight stigma against people who use drugs. If you're a patron, you also get free stickers which are personally mailed to you. You can also request a shout out on the show. And now patrons can even get 30% off of merch in our new store, which is at narcocast.myshopify.com. We have t-shirts and coffee mugs, one that says "There are drugs in here," which is awesome. More stuff will be added soon. As always, we are so grateful to the folks that make this show possible. A little goes a long way, so thanks for making Narcotica happen. We're ad-free and we want to keep it that way. If Patreon just isn't for you, that's fine. You can help us out by spreading the word. Tell all your friends about the podcast, advocating for social justice and abolishing the drug war. You can also rate us wherever you get your podcasts. Our theme music is by Glassboy, and Jenny Shea is the voice of Narcotica. Additional music is by myself, alias Nomad1, drug using producer. Well, I guess that's all. I hope you guys have a great rest of your day. Until next time.